All right. Good morning and almost good afternoon. And thank you so much for having me. My name is David Savage, and I am a medical oncologist at the University of New Mexico's Comprehensive Cancer Center. And about half of my patients have skin cancers, and a predominant number of them have advanced melanoma. And so I'm going to talk with you a little bit about things that can arise after somebody has completed their treatment for melanoma and just considerations for you all to have as people who are faced with melanoma or survivors of melanoma. I've got my email address here, and if anything I say kind of sparks your interest or you want to have more discussion about this, I welcome you to reach out to me. First, I just want to say that I've met several melanoma survivors here today, and it's really a pleasure to be here with you. I think that those of you who are long-term survivors of melanoma, or maybe you've just gotten through a treatment, that's such a commendable thing, and I really am super excited for you and hopeful for your future. But I want to talk about things that I think, as patients and providers of care, things that we need to think about with the kinds of treatments that we have now for melanoma. Let's talk about three different kind of broad categories of things. First, the potential financial toxicity of treatment and surveillance. Two, some side effects that can be very long lasting and long term from the conventional treatments that we now have for melanoma. And then finally, how this can affect mental health and quality of life for all people. So just to kind of give you a rough sense of what some of the things that we can do for people cost, and these costs are very ballpark, kind of taken from different resources online, very widely depending on health plans and health systems. But these numbers are pretty remarkable. Opdualag, which is a recently approved combination checkpoint inhibitor for stage 4 melanoma, it's given on a monthly basis. And depending on where you are and how you're insured, that can be almost $17,000 per month of treatment. Opdivo, which maybe some of you have received in the past, up to $10,000 per treatment. Keytruda, very commonly used, little lower cost, but almost $11,000 per treatment. And then some of the targeted therapies, the BRAF targeted therapies, $13,000 for a month of treatment. Well, for many people with health insurance and coverage, maybe a lot of this is covered by the insurance you have, and that's great. But I would say there's always going to be people who are underinsured or uninsured, and it makes some of these treatments inaccessible. But when you have stage 4 melanoma, you certainly don't want to not get these treatments because we know that these can promote overall survival. So it makes a really big conundrum for people. And I think it's something that we should all talk about and have conversations about. If you look at surveillance imaging, an outpatient PET CT at a minimum can be $2,500. In the health system I was previously a part of, it was billed out to the health insurance plans as $10,000. And that's for the device, that's for the radiologist with the expertise to read the scan. So if you're somebody who's getting a scan like this every 3 months, 6 months, 12 months, that can be a significant cost either to you or to the health system, and that can create some stress for patients and for their families. We had a little bit of mention earlier about the newest, greatest treatment that we have for advanced melanoma now, TIL therapy. TIL therapy right now, it is FDA approved, but it can only be given at centers with the expertise to do it. It requires about a month of being in clinic or being hospitalized, and that treatment right now costs around $500,000 to receive. So it's great that we have it, and I'm really excited. I think that's where melanoma care is going, but this can be very stressful to somebody who may be underinsured or uninsured to know that there's a great treatment available, but maybe I can't access it. Multiple studies have looked at the stress that the cost of advanced melanoma care can cause to patients and to their families. And many of you, as people who have maybe received melanoma treatment, might have experienced this, and it causes a lot of stress. If you look at, in one study, the amount and duration of debt, there were a lot of people who had $1,000 or more in out-of-pocket costs for the care that they received. Presumably, these are people with great insurance, people who most of their care is covered, but even $1,000 or more of out-of-pocket costs on a recurring basis can be very stressful. And then if you look at how long that debt lasts for a lot of people, there were 28% of people had debts that lasted for 3 years or more after getting their cancer treatment. This can be very stressful. even though you can be really excited that your treatment is going well and things are working, to have this extra burden of financial toxicity in your life can be really challenging. Maybe not surprisingly, people who are younger, when they have to go through these treatments, face even more stress. Maybe they're not as well established in their careers. Maybe they recognize that if they are long-term survivors, that the surveillance and all the testing that goes into that could last for a long period of time. And so it can cause a lot of stress, even though somebody has fully survived their melanoma diagnosis. And a top concern of many patients is their health coverage, especially since in the United States, health coverage is so intricately linked to your job. So if you have a treatment and maybe some morbidity from treatment or morbidity from your disease, and that prevents you from doing the work that you were previously trained to do, and maybe you lose your health insurance, and I've seen that case happen a lot, that can be very, very stressful to patients and to their families. But then, and it's not a surprise to me, but I think that healthcare providers don't ask all that often about how is this cancer care affecting you. 28% of people in one study reported that their doctors or healthcare providers actually talked about the cost of the care that they were providing. And in the same study, over half of people ended up depleting their savings, even though they were insured and they were having to pay the copays that went along with their cancer treatment. There were people who had to borrow against or use retirement money. There were people who had to use financial assistance programs through pharmaceutical companies, and that's something that I've helped a lot of patients do. There's people who skipped doses of medications, like if they were on the targeted therapy, rationed it, skipped it so that they could make 1 month's supply become 2 months' supply, or people who just postponed filling prescriptions because they just couldn't afford to do those things. And sometimes I think that doctors and healthcare teams are just not really aware of all the financial stress that people are under, because it's just in a limited span of time of an appointment, it's just not something sometimes that comes up or gets talked about. So that was financial toxicity. Well, immunotherapy, as has been mentioned a few times today, can also cause a different kind of toxicity. It's an immune-related toxicity. As you all recognize, the conventional therapies that we have for melanoma activate the immune system so that it can then attack cancer. But a conversation that I have with people all the time is that while that is amazing, there's a potential that the immune system can attack other things like your thyroid gland, your lungs, your skin, your GI tract, and cause adverse events that don't just stop because you stop the medication. More than that, we know that there is this thing called a chronic adverse event from immunotherapy. And as was mentioned earlier, the skin side effects and also the endocrine side effects, such as effects on the thyroid gland, can be some of the longest lasting and permanent. So this is, I think, really, really important when we're considering neoadjuvant, so before surgery, or adjuvant immunotherapy, because on one hand, you say, wouldn't it be great if we could prevent any kind of spread or recurrence of melanoma in the future? But on the other hand, anytime you provide an immunotherapy to somebody, you put them at risk that they could have one of these adverse side effects for months of time, or maybe even for the rest of their life. You know, I've seen people have needed to be on chronic low-dose steroids because of arthralgias from immunotherapy that they've had to be on for years beyond the termination of treatment. This is not to say we shouldn't use immunotherapy. It works. And I'll show you some data for that in a minute. But I think it's just an important consideration when we think about the survivorship plan of people with melanoma, because many of you are survivors in this room. There's a few of you who have survived for decades beyond the final treatment of melanoma, and that's amazing. But we, in addition to extending life, don't want to introduce morbidities that can challenge your life forever. There are other chronic side effects of the treatments we provide. You know, there's such thing as pain syndromes, where you can have the immune system attack nerves and cause chronic pain for people. There are the morbidity and mobility impairments from people who have extensive surgeries for melanoma and maybe extensive lymph node dissections, which cause debilitating lymphedema. There are people with hereditary risk syndromes and hereditary mutations that increase the risk of melanoma or other cancers, and that requires more screening tests, and it can lead to a fear or anxiety about having a recurrent cancer. people who have had a skin cancer of any type, but especially melanoma, sometimes are at risk of developing a fear or aversion to the sun because I think most people recognize that ultraviolet radiation is one of their risk factors for developing melanoma. And so if this has happened to you once, the idea of re-exposing yourself to the sun, although maybe it's a little bit irrational because we know that the sun exposure you get as a younger person are really what caused the melanomas in later parts of life. But this can be really, really anxiety and fear inducing for people who are survivors of melanoma. There also can be the inability to maintain employment. Maybe it's because somebody needs to be gone a lot for treatment, for surveillance scans. Maybe it's because somebody has some morbidity or disability from the surgeries or treatments that they've received. And this can be itself a toxicity of the treatments that we give. And then there's either biopsy fatigue. I know I was speaking with somebody earlier today who's had numerous biopsies, and I'm sure there's people in this room who have been in this situation. You've had maybe a couple of skin cancers, and as was alluded to in some of the presentations earlier, when you go to see a dermatologist and you have this really high risk history and you have some suspect lesions, there's a low threshold to say, why don't we just biopsy that or biopsy that to try to get an answer here? And for people that have been subjected to that for decades of life, that can be really hard. And there can also be this thing called scanxiety, where you've had melanoma, you've had scans in the past that have looked really, really concerning, and maybe things have gotten better because of immunotherapy or conventional treatments for melanoma, but there's always this worry that you're going to go back for that one last scan and all of a sudden things are going to be different. And I would imagine that can be immensely stressful. Immunotherapy can also attack the endocrine system. So we think of it attacking the thyroid gland, the pancreas, but it can also affect the entire adrenal axis, and it can affect somebody's fertility. It can affect their production of sex hormones. It can affect their long-term libido, and there's even some case reports that can affect the pregnancy of a person who is pregnant while receiving immunotherapy. These are very, very rare side effects, but I think as we're able to diagnose melanomas in younger and younger people, as people are receiving these treatments at a young age and then living for a natural lifespan, these are important considerations. And in one study that kind of looked at this, what are the potential toxicities on a reproductive focused basis for people who receive immunotherapy? Maybe not surprisingly, the people who are the folks that we need to pay most attention to are people in their reproductive ages, in their 20s, 30s, and 40s, both men and women, because they can have potential toxicities from immunotherapy that could affect their ability to grow their families in the way that they want to do. Another toxicity of immunotherapy or cancer in general are the mental health challenges that somebody can face because of cancer. So this was a Dutch pooled study they looked at an aggregate of studies, and in each of those, people had a thematic representation of depression, anxiety, fatigue, and cognitive concerns from having to constantly think about their cancer treatment, think about the cost of cancer treatment, and think about the surveillance and survivorship process as a part of their cancer journey. I think this kind of gets under talked about. When you have a 15-minute appointment with someone and you're really focused on, when's their next scan due, how's treatment going, sometimes we don't think about the broader holistic health of a person and talk about how their cancer care is affecting them as a human being. Another thing that I encounter a lot in melanoma care is what to do at the 5-year mark. Because for those of you who have had to face melanoma or any cancer, we are pretty proactive with the scans that we do for the first 5 years. We're very proactive about the surveillance in those first 5 years. But then you get to 5 years, you're a survivor, things are going really well. And a lot of guidelines have not too much guidance, or it's a very gray area about what to do after year 5. And this itself can introduce a lot of anxiety for people who are maybe used to the reassurance of a scan or a check-in with their physician to know that things are going okay and that maybe melanoma is not going to come back. We know that late recurrences do occur. This was mentioned earlier. I was a part of a study where we looked at a tertiary care center, and we found that a median timeline for recurrence was around 4 years. We found people with recurrences that were over a decade out. I just recently in my clinic had somebody with a recurrence that was 7 years out. So was disease-free from 7 years, asymptomatic, got a scan, and now has stage 4 melanoma. So we know that this does happen. And I would imagine for somebody who is a survivor of melanoma, this can add to the stress of the situation to know that, yes, I'm in the clear right now, but it could come back at some point. And how do we detect that? And how do we allow you to balance your living your life and doing the things you want to do without having this overhanging you like a black cloud? But I just want to close with some really good or exciting news. You know, we have now 10 years of data with our checkpoint inhibitors, particularly Opdivo or nivolumab, to look at, you know, how is the survival curve changing over time. And at the 10-year mark, you can see that for people that either got single agent immunotherapy, so that's the green line, or people who have got combination immunotherapy, so that's the orange line, you know, their survivorship at 10 years out is in the 45 to 50% range. So is everyone cured? No. But are there people who are doing well and kind of having a sustained survivorship curve at the 10-year mark? Yes. And that is incredible because when I started medical training, melanoma was really a hard thing to treat and people didn't have these kind of outcomes. And I think that as treatments improve, as TIL therapy gets perfected better, as the cost of that comes down, as center expertise improves where we can do it safely, these curves will start to look even better. And this is from the Journal of the American Medical Association, also from this year. And this was a pooled analysis, also looking at people who received these same drugs, either a single checkpoint inhibitor or the combination, which is the light blue line. And the data is essentially the same for that Checkmate 067 study of people, you know, around 45% of people are alive and well at 5.5 years. And that's really exciting news. So all this is to say that when we think about the treatment of advanced melanoma, it's an exciting field, and I think many of you who are here or who are online are a testament to that success. But we also want to balance the potential complications that it can introduce to life, and I think that all of us should be aware of those complications. The potential long-term side effects can include on your mental health, reproductive health, quality of life, and financial toxicity. And then finally, how do we mitigate? How do we control these tasks? Well, one thing is we should always focus on research and education. I know that the Melanoma Research Foundation has representation here. We also have the Melanoma Research Alliance, which promotes a lot of community education and research activities in the melanoma space. There's other community organizations which I think are amazing for people who have had an experience with melanoma. Aim at Melanoma, the YMCA's Livestrong program is something I've referred a lot of people to because it allows them to meet other people who are facing challenges with cancer care. And there's also local survivorship clinics. I was previously down at Scripps in San Diego, and we had a survivorship clinic for people who were beyond that 5-year period to allow them to still have regular touch points with the healthcare system to provide some peace of mind and to help manage their side effects. And I think we should all be aware of those side effects and really carefully have a vigilant eye for immune-related toxicities. And then finally, all of us, I think, should be aware of the cost of this stuff that we do to the healthcare system and to people individually, and try to be really on top of it so that it doesn't create or induce extra stress for people who are going through something that's incredibly tough, which is combating and dealing with cancer. So thank you all so much for having me. I've got my contact information here again. And if you want to talk more about this, I welcome you to reach out to me.
Questions? Go ahead.
I have a question from an online participant. Is there a certain point of time that changes it from a recurrence to a completely new melanoma?
Not really, but I would say that when you get really far out from that primary diagnosis and somebody gets a new melanoma, just by probability, there's a good chance that that next melanoma is a new melanoma. People who have had at least one melanoma have changes in their genetic material that just makes them at a higher risk of skin cancers in general. So that's with the study that we did at a tertiary care center. That's a challenge that we faced, is kind of distinguishing what people were having recurrences very, very, very late, or what people were having a second primary melanoma, because we know those happen as well.
One screen that showed the results of that. I'm trying to read it.
Okay.
And I gather that's Keytruda is the top one, the first one listed, but it comes
Yeah,
down
so the
lower.
first one is Yervoy, the CTLA-4
Is that the
inhibitor.
least effective then, or is that?
Yeah, that one
Yeah.
by itself has been shown to be less effective than the PD-1 inhibitors, and that's well described.
That's what I read. Okay, thank you.
You're welcome. All right. Well, thank you all very much.